the first set of the webinars for this year. We're very, very grateful that Purvi's joined us today for this. For those of you who don't know Purvi, she's a radiologist at Tata Hospital in Mumbai. And I will tell you, Purvi is what I call a clinician's radiologist. So these are people who understand that what we as clinicians need are able to really break it down for us. So since we've been seeing an increasing use of MRs for whatever reason, dense breasts, younger women, use of implants, I think I have found myself at a little bit of a loss on how to read them ourselves. We're always dependent on the radiologist. Some of our hospitals, of course, have fantastic radiologists who can help us understand these images. And then sometimes the patient comes with it done outside and you're seeing them somewhere else. And, I feel I'm a little lost with that. So we asked Purvi to help us go through this, understand how to read an MR from a surgeon's perspective and what we're looking at and how to map disease with it. So, Purvi, thank you again, and floor is all yours.
Okay, so first of all, thanks for that, and I hope I do justice in whatever time.
Sorry, can I request everyone else to please mute while we're on the session? And we'll get everyone to unmute when we're ready to start doing the questions.
Yeah. Okay, so I'll share my screen now.
Yes, please.
Is it visible now? Yeah, I hope it is.
Yes, it is.
So I think I did something wrong.
No, can see.
You can see.
Yeah.
I- 1 second. Uh, yeah, I think I can't see some things, but it's okay. Yeah. Okay, so hello everyone. I'm Purvi from TMH, and just 1 second, can you give me? There is some this thing which is
Sure. You want to log in, log out again? That also
just stop
works. Totally.
sharing and I'll do it
Yeah,
again.
sure.
Uh, yeah, now I'm okay. So can you can hear me and you can see my screen as well, right?
Yes, absolutely.
Yeah. Okay. So, so first of all, thank you for having me. And I'm going to talk about a lot of images and lot of about MR. And I hope that once we finish the session, you understand us better as a radiologist, and we kind of understand what questions that we need to answer when we are, reporting the MR. So, with that, let's start. So, what are we discussing today is basics of MR, and have included the newer BI-RADS, how we report with that newer BI-RADS, and we'll see some cases at the end. So it will be kind of some case that we see in the end. So, before we start, like, what is a basic or breast MR protocol? When you ask a MRI, what all sequences that we see? So this is a routine breast MRI protocol that we perform for all the patients. It has a T1 weighted image, it has T2 weighted images, star images, diffusion, post-contrast dynamic. Some places have ultrafast, so they perform ultrafast images. And sometimes there is a sagittal and coronal images SOS, depending on what protocol each hospital or each institution is following. So this is basic, and I'll talk about each sequences and what to see in each sequence as we go on. So this is a protocol. It takes around say 30 to 35 minutes to scan. Like each sequence take around 3 to 4 minutes to scan the breast, and the entire scan is around 30 to 35 minutes, depending on which kind of machine that they are scanning on. So with this, all so many sequences, what we see on each sequence, kind of this is important. Like, why do we need so many sequences? So there are some things which we can see on each sequences. Like on T2 weighted images, we can kind of see a basic pathology better. There are lesions which are very T2 bright, some lesions which are ISO or slightly hyper intense. T1 weighted images are important to basically delineate the anatomy of the lesion. So when I want to talk about, when I want to look at the margins of the lesion, I go and look at the T1 weighted images. Stir images gives you an overall picture wherever there is increased edema or fluid which is seen. Stir, you see a lot of fluid on stir images, so edema is better seen on the sequence. Diffusion is diffusion, like how much diffusion restriction happens in each lesion. So there are ways to use this amount of diffusion happening in different lesions, and we can kind of characterize lesions based on diffusion, the ADC values. The most important sequence in breast MR is dynamic contrast, which is the most important sequence to be acquired. Ultrafast, here routine dynamic or the conventional dynamic sequence, we majorly talk about washout kinetics, whereas this newer ultrafast sequence, where which has been now kind of very favorite with a lot of radiologists, where we talk about is wash-in characteristic of the lesion. I'll discuss each of this thing in detail. And post-contrast sagittal and coronal images are more kind of to locate the lesion exactly from a distance from the nipple, and more for localization rather than anything else. So this is how we use different sequences on MRI that we do. So this is a T2 weighted image, where on T2 is a sequence anywhere in the body, the fluid is bright. So when we do brain or abdominal MR, so brain CSF is bright, in abdominal gallbladder fluid or urinary bladder of urine in the urinary bladder, those they are bright. So when we are doing those part of MR, we can make out the sequence that this is T2, this is T1. Sometimes on breast MR, it is we don't see anything, any fluid which is visible. So it is difficult to kind of make out which is T1 and which is T2, and it is absolutely fine. There are for radiologists, there are these TR, TE values which are mentioned, with which we can make out which is T2 and T1. But whenever you can make out, so this is T1 sequence and this is T2 sequence, it's sometimes difficult, and it is, except if you cannot make out, it is fine. There I'll tell you what we see on each sequences, but so it is slightly difficult. So fluid is bright on T2, and fluid is kind of iso intense on T1. So this is T1, where the fat bright, same T2 fat is bright, and fibroglandular parenchyma is intensity is which is same as that of the skeletal muscle. So whenever we are talking about the intensity of the lesion, we kind of the comparison happens with that of the skeletal muscle, which is, you can see pectoralis. Sometimes you can see the shoulder girdle muscles also. So with that, you can make the intensity character. You can decide whether it is hyper intense or hypo intense compared to those muscles. Okay, so this is T2 and this is T1. So here you see the lesion very well. Here you see the lesion very well. You see this lesion, which is like an irregular lesion with speculations which are seen. And this lesion is slightly hyperintense on T2 weighted images when you compare it with the pectoralis muscle. Whereas this is at the same level, this is T1 weighted images. And here you see lesion which is more or less iso-intense to this skeletal muscles. Now, but if you see here, the spicules are seen well on both the images, but many times the spicules are so much better seen when you kind of see the T1 weighted images. So T1 is more for anatomy, to know anatomical to see if there is any architectural distortion surrounding it, or basically it talks more about anatomy, and T2 talks more about pathology of the lesion. Okay, so uh, what lesions are bright on T2 or stir? So stir or T2 fat sat is the lesions which are bright on T2 are also bright on stir. Stir is kind of fat saturated T2 weighted images. So simple cyst, lymph nodes, small fibroadenomas, uh, seromas or hematomas, and or ductectasia. These are bright on T2 weighted images. These will look like fluid on T2 weighted images and stir images. Some tumors like mucinous or colloid tumors also look very bright on T2 weighted images. Necrosis, where there is a fluid which comes, necrotic fluid, also appears bright on T2 weighted, T2 and stir images. Whereas on T1 weighted images, anything which is high protein or hemorrhagic content will show bright signal on T2 weighted images. So when there is a nipple discharge, bloody nipple discharge, we see ducts which are kind of filled with white color, very bright white fluid on T1 weighted images. So those are duct ectasia with high protein content inside the duct, or duct with the hemorrhagic content in the duct, show bright content on T1 weighted images. And fat containing lesions are definitely bright on T1 and T2 both, but the fat will get suppressed on fat saturated images. So on some lesions which are bright on T1 and T2 and show suppression of the signal on stir images are fat containing lesions. So especially in fat necrosis or hematomas, we kind of are looking for this change in the fat signal on stir and stir and routine T1, T2 images. So this is a stir images where everything on T1, T2 fat that you are seeing, which was bright, is now suppressed. This stir, there is some technical difference between the stir and fat saturated T2 images for like how the sequence is acquired. But for the breast MR purpose, both are similar kind of sequences. So here you see this lesion, which is very bright. Here the entire parenchyma is also showing brightness, but this lesion you can see bright. Now there is also something else also it tells about the lesion, that there is not significant kind of surrounding edematous changes. Probably this lesion might not be kind of very, very aggressive, where there is surrounding edema that we see in the breast parenchyma. So this is T2 and stir. So here you see lesion and you see the surrounding edematous edema. How much is the edema? Then let's move on to diffusion. Now, this diffusion weighted images, diffusion is a it's a different kind of sequence. So every cell in our body has proton, like a hydrogen inside every cells, and this hydrogen atom moves freely in between the cells, and it moves in the surrounding interstitial fluid. When there is a tumor, the cells are very compactly placed, and this hydrogen cannot move freely. So there is restriction to the movement of this hydrogen atom. This restriction of the movement of the hydrogen atom is kind of captured on this diffusion sequence. So here, anything that we see, when we say that there is a restricted diffusion, that means there is less mobility of this hydrogen. it means that there is this, and how do we see is we see that is a bright signal on diffusion, and this is a ADC map. We see a kind of a dark signal drop on ADC. When these two are present, like bright signal on diffusion and a drop in ADC, this is a true restricted diffusion. So whenever in your report it is mentioned that this lesion shows restricted diffusion, it means that there is this bright signal here and there is a signal drop. And it also means that there is a fluid, like the basic pathology of restricted diffusion is there is less freely mobile protons which are there in that lesion, and it is causing restriction. So there are certain lesions. So which kind of lesions show restricted diffusions? Is like all malignant lesion, most of the malignant lesion will show diffusion restriction. And with the values which are like, so now we also measure the ADC value, like the ADC maps that we saw. We measure the value, we put an ROI over there and we measured the ADC value. So this ADC value for normal breast is more than 1.5 into 10 raised to minus 3 millimeters square per second. That's the unit which is used. This ADC value, that is normal. Anything less than 1.3 is kind of suspicious. The truly invasive tumors have more low ADC value, less than zero point 0.8 or zero point 0.9 uh, uh, 10 raised to into 10 raised to 3 minus 3 millimeters squares per second. That is for invasive tumors. Some DCIs have a slightly higher ADC value in the range of 1.1 to 1.3. So there are a lot of studies which are kind of exploring the use of ADC as a screening modality in a breast cancer, where we can, if we can, whether we can replace doing contrast for these patients, and we just do diffusion, a good diffusion for those cases. So there they measure this ADC value, and it gives a idea about the nature of the lesion. There are more studies which are needed for kind of use this in the clinical practice for and skip doing right now skip doing contrast imaging. Right now we are doing it for all cases and kind of understand how to improve our diffusion sequence also, because diffusion, see, if not done well, diffusion, if you don't get a good image, like you don't acquire good image, you cannot really see this changes in the ADC value and the diffusion restriction. So this is about diffusion. Some of the lesions, like where when there are lesions where there is no free, there is a lot of surrounding fluid, like a mucinous tumor, or sometimes even in the lobular CAs, where the cells are not very compactly placed, you will not see diffusion restriction on those cases. So you kind of need to see how your T1, T2 sequences and everything else, and then interpret how you want to interpret the diffusion. So most of the malignant lesion will have a diffusion restriction, but some lesions known to not have diffusion restriction. Same goes with the abscess. Like abscess is like a kind of necrotic cells where there is less movement. So we see diffusion restriction in abscess. Lymph nodes, normal lymph nodes also show diffusion restriction because they are compactly placed as lymphoid tissue. And highly cellular benign lesions, sometimes very small, very cellular benign fibroadenomas also show diffusion restriction. So we are right now not in position to kind of only do diffusion and skip the other sequences, but maybe if we ever reach that stage where non-contrast breast MR come in clinical practice, the diffusion will be one of the most important sequence over there. So now then with that, let's move on to the most important sequence in breast MR. So till now what we did discussed were all non-contrast sequences. So breast MR, non-contrast breast MR indication is only one indication. There is nowhere else, in no other situation you can do breast MR without contrast. The only indication for doing non-contrast breast MR is when you want to evaluate implant rupture. Like you're suspecting implant rupture and you are doing the scan to evaluate only implant rupture. That scan will not tell you about the rest of the breast parenchyma. That scan will not tell you about any enhancing lesion. So, and for that, when you're doing for that implant, there are some different sequences like silicon select and silicon suppressed sequences, which needs to be performed in that kind when you're doing it for that purpose. For rest, all the indications, there has to be contrast. Without contrast, you cannot do breast MR. Matlab, it is incomplete study. So this is the most important sequence. So there are right now two types of contrast imaging. One is dynamic contrast imaging, which is like a standard or a conventional, which we are using it since few, almost now probably less than a decade or around a decade. Uh, we are using this sequence. So this routine dynamic contrast image. So how do we acquire this dynamic image? So there is it's a basically a T1 weighted sequence, which is fat saturated T1 weighted image. We acquire this sequence in a 3D manner in first without contrast, which becomes like a mask phase. And there are these 4 to 5 sets of images. After injection of contrast, we start acquiring these sequences. So then we have one which is without contrast, and we have at least 4 or 5 sets which is with contrast. And then a subtracted set of images, which will be more 4 or 5 sets of images, is generated using this uh, contrast enhanced sequences. So which first from this base raw images, you have a subtracted images which are generated. So most everybody uses this subtracted images to kind of interpret the result. There are times if there is any movement that happens between the mask phase and the first, second, third phase. In those situations, we might have to use this non-subtracted images, but I tell you that is sometimes is a suboptimal evaluation. So getting a good subtracted images is what we always want to kind of achieve. We don't want to have any movement which happens between these phases, so that subtraction doesn't happen well, and then the images are not good, and no radiologist is happy over that. So this is how we acquire. There is a mask phase, and there are 5 phases of the images acquired, and then we subtract these phases and we create a subtracted set of images. How do these images look? So this is how it looks. This is a first subtracted images. Here, what we are seeing in this image is only contrast, which is kind of subtracted from the mask phase. So this is the first phase. This is the second subtracted phase. This is the third phase, and this is the fourth phase. Now you see this lesion showing enhancement. You're seeing kind of speculations which are seen well, and you are you are seeing the lesion. So one more thing that I would also want to show you is sometimes you can also determine the kinetics also, looking at this images. Now this is my first image, and you see how much is the enhancement, and now then I go and look at the last image, and I can see definitely there is this intensity which is dropping from first image to the last image. So this lesion is probably has kind of a washout which is happening from the first image to the last image. So you can kind of get an idea about kinetic curve about of how those kinetic curves are. You can see the images and you can kind of guess that this will be a washout kind of kinetic curve for this images. So with that, let's see what are those kinetic curves, because I'm sure a lot of the reports mention wash in, wash out, type 1 kinetic curve, type 2 kinetic curve. So what does it mean basically? So now, again, as I said, there are 5 or 6 sets of images which are acquired. The first is, this first phase, second phase, third phase on the timeline, and the intensity. So inside the lesion, suppose when I draw a small ROI, which is like 5 to 6 mm, yahan par if I've drawn an ROI, so my machine will calculate at the same ROI on all phases the change in the signal intensity at that location, like how much is the change in signal intensity which is happening over the time, like over this 5 sequences, and it will draw a this kind of diagram for me, and it will show that this was the first, then this is the second, or this is the first, second, third, and fourth phase, and it will draw me a curve. So that is called as kinetic curve. Now this kinetic curve has an initial upslope, like it goes to a maximum signal intensity, and then it starts to fall down or there is a second phase, which is a delayed phase, what we call it. So routine conventional dynamic images, kind of, we use this washout kinetics to talk about what's happening with the disease. Like we talk whether there is a washout which is happening from the initial increase till the peak signal intensity. There is washout, as we saw in this case. There are sometimes the kinetic, the signal intensity remains stable, or there is a persistent increase, slow persistent increase in the signal intensity, depending on which we decide the type of the curve. This will be like where when signal intensity reaches maximum and it starts to wash out is washout kinetics. This is plateau, and this is persistent kinetic curve. So this is how we define, like if it goes to the maximum signal intensity and then intensity remains within 10% plus or minus of the maximum intensity, it is called as plateau. More than 10% increase is a persistent kind of kinetic, and more than 10% decrease is a washout kinetics. So this is how the kinetic curves are measured. So many times you can kind of just see the images, you can see all the images, you put all the images together, and you are able to kind of talk about kinetic, uh, what's happening to the kinetic, curves, what kind of kinetic curves those images will have. So that was about the dynamic contrast images. Now, which is routine dynamic contrast. Now, this is like, now it is also my favorite. Also, one of the newer sequences is ultrafast dynamic contrast enhanced images. Now, this ultrafast images are basically, there is some kind of advancement in the technology of acquiring the images that has come, that these sequences are very, very fast. Like where in the dynamic contrast, each phase, like 0, 1, 2, 3, 4, 5, each phase took around 35 to 40 seconds to acquire. Here we are able to acquire that entire phase in 3 to 4 seconds, or sometimes 5 seconds. So entire breast is scanned within 5 seconds. So it's really super fast scanning that happens. So uh, uh, here also same thing. Here we take mask phase and then multiple phases, and then we subtract the images. The same way subtraction happens. The difference being, here we do take more phases because some lesions do have kind of not so early enhancement, and they are benign lesions, especially show enhancement in the last phase. So typically in the ultrafast, when we are acquiring ultrafast sequences, we typically take around 9 to 10 or sometimes 11 phases to know exact kinetic characteristic. Now, again, so now this, as we were talking, this was something that we kind of explore when we are doing a routine dynamic imaging, which is with the 35 to 40 seconds time. But when we're doing the ultrafast scan, we are kind of finishing the ultrafast sequences in this first phase. So we are basically looking at the wash in kinetic and not the wash out kinetic curves. So this is, found to be more specific in terms of lesion characterization, the wash in kinetics, like how the lesion is enhancing, how fast it is enhancing, because the neovascularization, it shows very early enhancement. So how these ultrafast images look. Now, see, I have this ultrafast images here. This is the first phase. Like for, kind of easy understanding, I've kept this marking here. So this is first phase, second phase, third phase, fourth phase, fifth, sixth, seventh, and eighth. I couldn't take all the 10 phases here. So now you see, when you have this ultrafast images, you actually see how the lesion is enhancing. This phase was, we have started taking phase as soon as we kind of start injecting, we start taking this sequence. So in the first phase, we don't see, this is the heart, we don't see contrast anywhere in the heart. Means it's still probably in the venous system and it's still not reached the heart. Now here is the second subtracted phase of ultrafast sequence. Here we see contrast only in the heart. There is nothing else which is enhancing inside the breast. Okay, so this, and you also see this is like a more in the right ventricle than in the left ventricle. So it's the contrast is probably yet to enter, or it has just entered the left ventricle. Now here, this is the third phase. Now here, the heart is enhancing well. I do see some vessels also in the axilla or showing enhancement. Internal memories were seen before also, and there is something which has started coming in the breast. Now, this is the fourth phase. I do see only the breast, which is the lesion which is enhancing. There is nothing else which is enhancing in the breast. This fourth and fifth phase, tells me uh tells me about the lesion. Like, okay, only the lesion is enhancing. And then as I move ahead in the sequences, the seventh, eighth phases shows a lot of enhancement in the rest of the breast parenchyma. This is basically a background parenchymal enhancement. So this background parenchymal enhancement started coming later in the sequences. I would say from sixth sequence onwards, we are seeing background enhancement. But for the fourth and the fifth sequence, there was only lesion which was enhancing. So, this BPE is, which is kind of, no radiologist likes a lot of BPE because it masks a lot of lesion, and we are not happy with that kind of scan. We're not confident to kind of report, or are we missing something. That thing always stays in the back of the mind. So this is what the ultrafast sequence helps us, is kind of before the BPE starts coming in, the lesion has already enhanced, like that washing has happened inside the lesion. And this is, when I scroll this image, like the fourth phase or the fifth phase, and I don't see anything enhancing. And when I do ninth or tenth phase, I see a lot of more lesion enhancing. I kind of know, okay, those are probably benign, or those are something which is kind of delayed enhancing lesions, part of benign pathology. My disease is located this much, and I should kind of focus on this much. If I find any additional lesion, I will go and do the relook ultrasound for those lesions which I see in the early phases of enhancement, early phases of this ultrafast sequences. So this is in nutshell about the ultrafast sequences, which is kind of very nice. So only difference between the ultrafast and the routine dynamic scan is, because that routine dynamic scan takes like a longer time, around say 35 40 seconds, that as I mentioned, it has got a very good spatial resolution. Yeah, you see in this sequence, you can see this speculations, that irregular margins very well when you see this images. This kind of resolution is not there in this ultrafast sequences, because this sequence kind of, there is a very good temporal resolution. Temporal resolution means there is it takes like a very short duration, and it takes a lot of scans, but there is a poor spatial resolution in this sequence, whereas this dynamic sequence has got a good spatial resolution. Like we kind of see the entire lesion well, the margins of the lesions well. So that's the basic difference. So we right now we do take ultrafast sequence also, routine dynamic also, because probably to kind of know this spatial resolution better with this sequence. So we are still taking both the sequences. So we start with, we do the mask phase, we inject contrast, we take a ultrafast sequence. When it finishes, immediately the routine dynamic sequences start, and we kind of probably decrease the number of routine dynamic sequences, and we do the scan for these cases. So hope I kind of made this contrast, uh, how to interpret the contrast images better. But now let's go on to the most important part, which I think you all will like it, is to look at this MIP images. So what are this MIP images? MIP is the short form for maximum intensity projection. So here, what happens is, uh, you take a set of subtracted image, and then you kind of increase your slice thickness. So I'll go back. So I'm going to the first phase. Suppose I open this phase, and I slowly this slices are I think around 1.5 millimeter thickness. If I slowly keep increasing my slice thickness, and I cover the entire breast, and whatever the images. So I will only get the where there is an enhancement which is there. So that image is called as MIP images. It just shows wherever there is a maximum intensity inside the breast, like wherever there is the highest enhancement which was there in the breast. So these are MIP images. So this is only one image is created per sequence. So if I have kind of four phases of dynamic, then I will create four MIP images. But this is something which is very important for you. When you see this one image, you definitely know, okay, there is this one lesion here, one lesion in right breast, one lesion in the left breast. Only thing is you may have to make sure, like it's like a CC view of our breast, but with the minus all the background parenchyma, and you are seeing only the enhancing lesion. So this something is a sometimes we start with this image, we see the MIP image, and then we decide how much, faster you can report this scan, like how much time you want to spend on each sequence is going through and what lesions you want to kind of evaluate in more detail. So this is like a CC view, as I said, and it's fastest way to kind of scroll through the entire breast scan. So when the abbreviated MR protocol, Dr. Christina Kuhl, who kind of first proposed the protocol, and she did her study. They just saw this one MIP image, and they evaluated, and that this patient needs a relook, or this patient needs to be seen again, or this is normal scan, just by seeing this one sequence. So for that, this was the sequence with which this abbreviated protocol which came in practice. So contrast imaging, MIP sequence. If four phases, you will have four MIP images. Now, sometimes this also happens. This is like an extensive background parenchymal enhancement. And here, even the MIP images, on MIP images, it's everything is entire parenchyma is enhancing, and you are absolutely not seeing anything. So here you have to go back and kind of see each and every slice and see what is happening at each slice level and where is the disease in the early phases. So with that, I kind of, discussed about the what all sequences that we have, what we see on those sequences, and how do we see the scan. I thought I'll just talk to you in brief about this the newer BI-RADS which has come in from December 2025. This new BI-RADS came in, and it is these BI-RADS lexicon summaries there on ACR websites available to kind of have a look at it. So I will just discuss this when we are reporting. We most of the reports you will see everybody following the BI-RADS lexicon. So I just thought I'll kind of tell you what, when we report, what it means when we write down some certain things. So BI-RADS lexicon talks about the amount of fibroglandular parenchyma to be mentioned, background parenchymal enhancement to be mentioned, mass lesion to be mentioned in certain ways. I will discuss these things in kind of short time. So first, let's start with the amount of fibroglandular parenchyma which is there on the breast, because this itself, this is like a this correlates with the density of uh, uh, um, density on mammogram, like how much is the parenchyma. This FGT is correlates with the density on the mammogram. So this it's, and the lexicons are same, almost entirely fatty scattered fibroglandular parenchyma, heterogeneous parenchyma, and extremely dense parenchyma. So this is similar here, but it will be on the T1 weighted images, T1 non fat set images, which on which we determine the fibroglandular parenchyma. So this is almost entirely fatty scattered fibroglandular parenchyma, heterogeneous fibroglandular parenchyma, and dense fibroglandular parenchyma. Then the second lexicon is a background parenchymal enhancement. Now, this background parenchymal enhancement, again, there are these four lexicons which are mentioned for that, which is minimal, mild, moderate, and marked. So this is minimal background parenchymal enhancement, mild, moderate, and the marked that we just saw. So this is something which is kind of masks the everything. Masks matlab this everything. So when we say background parenchymal enhancement, it's not same as BP, the amount of fibroglandular parenchyma. This is the enhancement which we see on the subtracted images within the breast parenchyma. And this is what gets affected when the scan is not done in a right window from 7 to 14 days of the menstrual cycle. If we do it like in the just prior to the menses, if even if the patient had suppose mild otherwise mild parenchyma, if we had done it in the that proper phase, we might see little higher BPE in that phase. So this the grading of BPE changes with the menstrual phase, and this is basically sometimes masks the detection of the lesion if it is moderate or marked background parenchymal enhancement. That's why if it is not a diagnostic scan, if it is a screening breast MR which is to be done, it's best to kind of maybe postpone it for 10-15 days and then do it in a proper phase to kind of get the least amount of background parenchymal enhancement. And the again, second thing is again, when we are using the ultra fast sequences, we are trying to kind of uh, go faster and take the images faster before the parenchyma, this BPE starts appearing. So this is BP. So that again also needs to be described as symmetrical and asymmetrical. BP is like more of a picture frame kind of an appearance where laterally, inferiorly, and posteriorly it is more enhancing than it is a symmetrical background parenchymal enhancement, and everything else is asymmetrical. And sometimes we can confuse an asymmetrical background parenchymal enhancement with non-mass enhancement, and we ask for biopsy, and it can turn out to be kind of a benign breast tissue because it was probably an asymmetric BPE, which we thought probably was a non-mass enhancement. So that was about how the breast composition is on the when we talk about the lexicon. Now let's move on to the mass. So when we describe mass, we describe about the shape of the mass, we describe margin, how it enhances, like the internal enhancing characteristic, and how it was on the non-contrast T2 aided images. So there are these four shapes: oval, lobulated, round, irregular. As you go down in from top to bottom, the suspiciousness of the lesion increases. And here, margins. So the shape is shape, like a round is a shape, or a what I say is a ball is a shape, or a cricket ball is a shape, and the rugby ball, these two are shapes, different shapes. But as we see on the margin is like Monaco biscuit has a irregular margin, whereas Mari has kind of a circumscribed margin. So that's the difference between the shape and the margin of the lesion. Then, so I'll show you some shapes. This is like an oval, and probably there were some lobulation. So this is oval lobulated. This is round. This is again a round lesion, whereas this is very irregular lesion. This has got an heterogeneous enhancing pattern, whereas this has got an homogeneous enhancing pattern, homogeneous enhancement, whereas this is a non-contrast. So here we don't talk about the enhancement. And same with the margin. So this is circumscribed margin, like where you see the entire lesion well, or at least 75% of the lesion you see very well with the circumscribed margin, whereas non-circumscribed is where it is an irregular margin, like there are irregular margins. And spiculated is you see spicules which are kind of coming out through this lesion. So that is spiculated margin, irregular and spiculated. Then it's homogeneous and heterogeneous enhancement. There are other types of enhancement. This is dark internal septation or dark non-enhancing septation. This is very classically seen in some fibroadenomas where we see like very oval or lobulated lesion with circumscribed margin and has got this dark non-enhancing septae. Then it is more or less characteristic of FAs, fibroadenomas. And thick rim enhancement, sometimes it only see at the periphery of the lesion, we see enhancement. This kind of enhancement is more like is seen with the round TNBCs, where you see a thick rim enhancement. How we saw that diffusion, whereas there was like peripheral rim, which was diffusion restriction. Similarly, we see like a peripheral thick rim enhancement. And signal intensity, we discussed how signal intensities are. And then after that, let's move on to the non-mass enhancement. What is non-mass enhancement? So where we don't see a unique mass or something which is three-dimensional, which has got its own shape, we don't see that on T1 and T2 and stir sequences, then and we just see that enhancement on post contrast images, then it is non-mass enhancement. Now this non-mass enhancement is to be described with two lexicons, like one of the distribution lexicon and one is how is the enhancement characteristic. So how we describe calcifications in pleomorphic calcification in segmental distribution, or linear branching calcification in linear distribution or segmental distribution. Same way, non-mass enhancement needs to be described with the two descriptors. One is distribution, like whether it is diffuse, regional, focal, linear, or segmental. Again, if you go from top to bottom, the suspiciousness of the non-mass that enhancement to be malignant increases. And how is the enhancement, internal enhancing characteristic? So more distribution and distribution and the enhancement characteristic will you need to describe that when you're describing the non-mass enhancement. So it's the same thing. I'll show you some examples. So this is like a focal area of non-mass enhancement. Whereas here you see this is the mass, and you see this anteriorly, which is going, is a linear non-mass enhancement. In this case, there is this V-shaped triangle which is towards the nipple. So this is kind of a segmental distribution of non-mass enhancement. Some one region, when it is enhancing, it is regional non-mass enhancement, and diffuse is, it is entire breast is diffusely involved. So sometimes these are the cases where it is less likely to be malignant, where I want to kind of definitely not pass on this linear or segmental non-mass enhancement, but sometimes I would diffuse enhancement and I might just want to do a short-term follow-up. Then the internal enhancing characteristic, when it is a homogeneous, like it's similar, or heterogeneous enhancement, some area is enhancing more in some area. And then there is this clustered ring. You see of enhancement or some non-enhancing areas in between. Those are within that area of mass enhancement, that is clustered ring kind of enhancement. This is more commonly seen with kind of DCIs, where there is periductal inflammation, periductal increased vascularity shows that increased enhancement that we see with the clustered ring. So that it also talks about, sorry, I'm going back, is also talks about the kinetic curve. This we already discussed, like how is it washing characteristic, what is happening in the early phase of kinetic curve and what is happening in the delayed phase of kinetic curve. Then it also talks about the other structure, other thing, intramammary lymph node, axillary lymph node. There are very criteria to call when it is suspicious intramammary lymph node, or suspicious axillary nodes, or suspicious internal mammary nodes. And then it also, we have to discuss about the associated features. What is happening to the nipple? Is there any retraction in nipple involvement, skin retraction, chest wall involvement, and pectoral muscle involvement, and also about peritumoral edema, as I was, I mentioned about, it's better seen on stir or T2-weighted images. And other features also needs to be mentioned in the report is like cyst or anything else from this. This, whenever you kind of see a very cyst is something, when you see T2, T1, T2 bright and non-enhancing cystic area, you can directly write cyst. You need not write it as oval region lesion showing this characteristic curve or this kind of enhancement. Then the Byrad's lexicon also has a section on how to kind of interpret the implant when the MR is done for the implant, and what kind of implant is it. So this is entirely a new, different topic, and probably we won't be able to cover this today. But it mentions like how do you report an implant, and then in the end it talks about the assessment categories. Like after the scan in the impression, we always write what kind of BI-RADS it's kind of showing. Now, here it is either negative, benign, probably benign, where you kind of need a 6 months follow-up, or surveillance at 12 months, and the likelihood of malignancy is less than 2%. Now, this BI-RADS 4 category, now mammography has this BI-RADS category divided into A, B, and C, whereas breast MR uh, still doesn't have it. Even in 2025 edition, it still does not kind of categorize lesions as BI-RADS 4A, 4B, 4C. We do at times, or many times, when we are discussing with anyone of with surgeons, we say it is like a probably. So when I have given BI-RADS 4 for small lobulations or some internal enhancement which is heterogeneous, it's not kind of homogeneous enhancement, my level of suspicion for those lesion is low. So I might say it is probably like 4A type of a lesion. But as per BI-RADS lexicon, there is no subcategorization for breast MR. And then there is 5 and 6. The other category remains, rest everything remains same as that of the breast, uh, mammography, the BI-RADS assessment categories. So with that, let's kind of see one case, and then we'll see if you want to see. I have some cases on the link which is created, and you want to see some MR on your own, we can see that together. Or we can see it together, or you can see it on your own, and we can discuss. So here is a very first case. Let's see. Is a dense mammogram, and other than this one lesion, which I also probably can't make out really, it's probably here on the CC view. I don't see anything else in the breast parenchyma, and this is like an heterogeneous to extremely dense breast parenchyma. We did an ultrasound. There was a lesion at 5 to 6 o'clock or 4 to 5 o'clock position at irregular hypoechoic lesion with angular margin, and probably this must be around 2.5 centimeter in size. There is no significant internal vascularity. This is very, very hard on elastography. And we also found some lesion at 12 o'clock position in the breast. Now, this lesion has a single kind of an angular margin. So this will go as BI-RADS 4A for me. I will give it as 4A because of this angular margin for this lesion. We had done MR for this case, and let's see the MR. And kind of probably now, do we want to do some interactive, or I'll discuss this and then we do some interactive
No, no. Happy to
kind of
have
Q&A.
um, questions on it. So if
Yeah,
you
yeah,
want
sure.
someone to sort of point out anything, I'm
Perfect.
not
That
going to volunteer, but if anybody else wants to.
yeah. So is anybody willing to, or I should I go? I see a lot of known faces, or are known names in the uh,
So is
so
anyone willing to volunteer to sort of say what they are seeing?
go through the case together. I will see it. We'll do
Yeah,
it together.
she's going to obviously tell us that, but
Ma'am, this is the same image that you showed us where there's that lesion in the breast on the lateral aspect of the left
Yeah,
side.
it's the same case. Yeah,
Yeah.
this is the mammogram. This was the mammogram, and this is the ultrasound images of the same case. And ultrasound in the left breast, we found the lesion at around say 4 to 5 o'clock position, and this was the finding. And this is the MR. This is a T1 weighted image.
Everyone. And in this, you can see the speculations, is what you said.
Yes, they are very nicely seen, the speculations here. Yeah. So then this is a T1 weighted image. Now this is a T2 weighted image. Now here you see this is slightly hyper intense when I compare it with the skeletal
Yes,
muscles.
skeletal muscles.
Yes, so this is a slightly hyper intense on T2 weighted images. I kind of the diffusion that I showed you in the prior when we were discussing is the same case. Sorry, is the same case. So diffusion, you saw that peripheral diffusion restriction in this image. And this is a MIP image of one of the delayed phase where we're seeing the enhancement here. But there is a lot of background parenchymal enhancement in the rest of the breast parenchyma. And this is, you want to say something, Vasila, here? Like this is the same that we discussed again.
Ma'am, we have questions regarding this. This is the ultra fast sequence, right? So you can see the contrast reaching the heart in the beginning. And as we give it a few seconds, it reaches the heart and then it reaches the axillary vessels and then it slowly enters the lesion. And then it starts to see more and more enhancement in the lesion. But again, I've never seen this image before.
Yeah, no, that is perfect. So that is absolutely, this is the same image that I took it again to kind of, now we see it with how it is seen with the mammogram ultrasound picture, and when we compile everything together and what how do we reach the final this thing. So this lesion is showing enhancement and it is seen very nicely. Now, this was this lesion, that 12 o'clock lesion did not show any enhancement, which was there in the breast on ultrasound. This lesion was not showing, sorry, I'm going back again. This was not showing any enhancement. So there are some studies now where it talks about when it is absolutely not showing any kind of enhancement, you can downgrade those lesions which were of higher BI-RADS on your ultrasound and mammogram, and it's not showing any enhancement. You can downgrade those lesions to lower BI-RADS, and you can follow up with the ultrasound.
Does that happen in the clinic? Because usually when we end up taking an MRI, we usually end up with a higher BI-RADS. Do we expect that an MRI would downgrade it and allow us to follow up?
Yes, it does. Even CEM does in that matter. Some of the lesions which do not show absolutely no enhancement, but maybe had some one or two lobulations, microlobulated margins for which we had given a higher BI-RADS on anatomical imaging, which is ultrasound and mammo. We do downgrade those lesions on once we give the contrast, and it is not showing absolutely no enhancement, and we do downgrade those lesions. So this was, so this is a single lesion in the breast, extremely high parenchymal enhancement, and the lesion which is seen in the lower outer quadrant of the left breast, and nothing else in the rest of the breast parenchyma. So many times when we ask for an MR, like when this is something where we don't see anything enhanced, like when you're doing a BCT, we want to see that there is nothing else which is enhancing, and this is kind of a safest place where we don't have any doubt for any other lesions which needs a histopathology again here. So I have some kind of case. If I can share the link of that, and if you want, we can kind of see that on uh, uh, see yourself, or else I can open it here as well,
Yeah, so
however
I
you
think,
want.
Purvi, if you can open it here and we can go through them with you.
Sure. Okay, so I will stop sharing this and I'll just start that case. Hmm. I'm sharing my screen again. Yeah, it's visible, right?
Yes.
So, Purvi, before you start the cases, maybe we just sort of do a quick brush up. We are
Sure.
looking at T1 images will give us sort of fat and whether there's any density in the fat. T2 images is where we expect the fluid to show up brighter.
Yes.
We are looking at kinetics in terms of delayed washout and early wash in for
Yes.
malignancies.
Hmm.
And we had some questions in the group which were ducts with hemorrhage should be brighter on T2 since fluid is brighter. So do we expect to see DCIS
No.
or
So
lymphatic ducts as darker,
No, so
brighter?
ducts with the of hemorrhage within it,
Hmm.
the intensity or the content of that hemorrhage, the oxyhemoglobin and deoxyhemoglobin in the hemorrhagic duct changes the reflexivity of the MR. So the hemorrhagic fluid, if it is within the duct, it will be brighter. If it is so that will be seen on T1 weighted images.
Okay.
If it is fluid, which is fluid, like there is no very high protein content fluid, like those patients where we do MR when she's lactating, where
Hmm.
it is there is a continuous flow and it's not very high protein fluid, then those are bright on T2 weighted images. Whereas duct ectasia, which is not kind of draining inspissated secretions, they are brighter on T1 weighted images.
Okay. And ILC will show diffusion restriction which is limited or it will
Uh,
show any diffusion restriction.
So ILC depends, like some of these ILCs are architectural distortion predominantly. So where we don't expect a very high diffusion, the ADC values will not drop to 0.8, 0.7. It will remain on a higher side, probably 1.2, 1.3, or 1.1. So it will not show significant restricted diffusion because it's not forming kind of mass or compact cells. The basic IL, those cells are diffusely scattered. So we won't see very high diffusion restriction.
Okay. And you basically expect to see segmental non-mass enhancement primarily in which sort of
DCI.
no, so in which phase? What are you're going to look for it in which sequence?
In the contrast, the ultrafast or dynamic contrast, wherever you see the that segmental appearance. See, the phase, the important is you need to differentiate it with BPE, background parenchymal enhancement, because this is non-mass. Like you will not see any correlate on T1 T2 weighted images. You will just see this enhancement on your post contrast subtracted images. So sometimes, like in ultrafast that I was showing you, so this again, the non-mass enhancement where there is not as much high neoangiogenesis as invasive CA, you might not see it in fourth phase, fifth phase, but maybe sixth or seventh phase, you will see the enemies coming, and then delayed phases, you see BPE coming. But it is like where there is lots of neo vessels, there you see very fast lesion showing enhancement. Then it will come to the non-mass enhancement, and then it will go to BPE. But that distinction sometimes is blur between non-mass enhancement and kind of BPE enhancement. Sometimes everything comes in together. But wherever you see that morphology of segmental distribution, it is you either see it on subtracted sequences, and probably if you're using a dynamic phases, only dynamic, and you don't have ultrafast, then the best phase or the best MIP is the first phase of your routine dynamic sequence. That will give you the maximum idea about tumor, and less that will have the least BPE. I hope I answered your question. I probably didn't get it well, so I kind of
I think that sort of does cover most of that. So I think one of the questions, which I don't know whether you're going to take in the cases as you go along, is that if you've got, how do you topographically map from an MRI for us as surgeons. So let's say, you told us the segmental non-mass enhancement, and I now need to visualize in my head how I'm going to excise this in that breast.
So here now
Are there any keys for us there?
Yeah. So here, this, when we do an MR, the patient is prone position. The breast is hanging down. They literally kind of hang down from the chest wall, and it goes till this. Sorry, I do have an image here. Like, this is exactly how this scan is not you can see my screen, right? Yeah,
Yes.
this scan is not rotated. Most of the times we do get a rotated images and it comes on the prex. It has not come. So the breast is literally hanging down. So the clock position here is not the same as what we do on ultrasound, the clock
Correct.
position. Yeah, so here we see the nipple, like where the nipple is, so for me, just take this. This is better. So this is from where I'm going from top to bottom. So to see that, like whether you're going from top to bottom, we look at the liver and look at the great vessels where they are when you are looking at the scan. Most of the time, if you are seeing the films, it will always start from top of the top to bottom. But if not, you are not able to make out, and it is because the breast, that anatomy wise, there is no structure which you kind of tells you which is the top and bottom. So you go from, you can see some part of the abdomen or the chest wall, chest, which is visible. So you can decide this is probably up, and then everything that I go down, it's going to be 12 o'clock here, and then you reach till the nipple. This will be 3 o'clock and 9 o'clock, and then you go down and it will be 6 o'clock. So again, the same way, I'm going to rotate this because this sometimes is, this is the way that we see the MRs. Okay, so you go from top, you see the chest wall, the great vessels, and then you go down, you see the liver. So you now kind of, you saw from top to bottom, and then same way how we see on mammo, the clock position. So from top, the same way is the way we kind of, when you are scrolling on the images, you will
So
be.
I would think, Shafiq, if you want to sort of comment here, since the question was yours to raise, is when you start from the top, what you're looking at would be 12 o'clock. When you come to the bottom is what you're looking at 6 o'clock. 3 and 9 obviously is based on position. And you would expect that topographically we are mapping both depth as well as width by going down the image, is what you're suggesting.
Yes, matlab,
Right.
so
Yes.
Yeah.
yeah, sorry.
Yeah, that's what I wanted to know. I think what we can get from the radiologist is the coordinates. And then we'll have to map it out on the breast as such. So
Yeah.
I also would like to know if these cases of NME, do they have some subtle clues on ultrasound? How often
So
are they seen on a second look ultrasound?
So we do go down and see multiple times. Sometimes we do find subtle areas of, those non-mass areas on ultrasound. We do see sometimes those non-mass areas. And so see this, the confidence is more when there is nothing else in the breast parenchyma. If my entire rest of the breast on ultrasound is very homogeneous, like very homogeneous fatty or very homogeneous fibroglandular parenchyma, then I'm able to identify those subtle areas of subtle non-mass areas, and probably I can mark that for you. But if the breast is very heterogeneous on ultrasound, which sometimes we do see as a heterogeneous parenchyma, then my confidence to mark that, I'm not sure that what I see on MR is the same area which I'm marking on ultrasound. So in such cases, I would rather not mark it on ultrasound. I would probably want you to kind of go, either do it MR guided intervention, or we give you some, more topographic evidence, because if I mark something and I have not marked the correct area, we are kind of not addressing the right pathology, and it will be false, this thing, this falsely negative result that we will see. So to answer the question, sometimes, yes, we see this correlate on relook ultrasound, but sometimes we don't. And those are the times that we want to do the MR guided interventions.
No, what?
Okay.
Okay, thank you. Thank you so much.
We also have another question which says, what is your opinion on diffusion weighted MR elastography to assess response to NACT?
So in that case, so I don't have experience with MR elastography, but I do have experience with ultrasound elastography for assessment of response. We have a study which is going on. We've kind of done 92 patients of that, and we are kind of seeing the elastography values on baseline ultrasound and after 2 cycles of ultrasound, 2 cycles of NACT, and then correlating with the final HPR. And we are getting a change in the values, and which is kind of significant change in the values. We yet to finish to get like full 110 patients for the study. But ultrasound elastography, after 2 cycles of NACT, we are able to predict the final PCR or significant response or no response. But I don't have experience with MR elastography on that. There were some sequences which were going to come to our institution for doing that, but it's not come. So I'm sorry, I cannot answer that question.
Last 2 questions before we go back to the cases is, does the size of the breast filling the cups of the machine influence imaging?
It does not influence imaging as such, in the sense, many times we have seen, like, if it is very large breast, the anterior part almost touches the base of the coil, the breast coil, and in that case, uh, kind of, to localization of the lesion becomes slightly difficult, like whether it is 3 o'clock, if it's near the nipple. But otherwise, if the most important thing is to get the entire breast the inside the those cup or the coil, the in the inside the coil, and scan the patient. So the limitation here comes with the total weight of the patient. So if the weight is very high, every machine has a different cutoff values. If the weight of the patient, the entire weight of the patient, is more than that cutoff value, then your machine will not take up that patient for scanning, or patient will not be able to enter the gantry. But other than that, I don't think so. If the most of the time this fits inside the breast, if it is too large, we will see like it's kind of fills up the anterior end or the base of the coil, and we see like a contour change on this image, like it will become flatter here. Enhancement it should not change, and it doesn't change.
And I think what Anushri is basically asking is what most of us want to know, is that can you then start seeing non-mass enhancement on contrast-based mammography? And does that correlate with MR and non-mass enhancements seen on MR?
Can you go back to the question?
CEM versus MRI. Would
Okay.
the non-mass enhancement on CEM correlate with that on MRI?
Yes. So MR is more sensitive, like it will pick up this tiny small area of enhancement. So if it is a large area of non-mass enhancement, CEM will also pick up, because the basic the enhancement is because of the neoangiogenesis. So both will show non-mass enhancement. But the CEM is more specific in terms of the lesions which are seen on CEM are more they are more specific. In the false negative of MR is higher than the false negative of contrast mammogram. I hope that answers the questions.
Sort of. All right.
Yeah.
So do you want to just run through a few cases? I think we can.
Yes, yes. So I have this case, and as we were discussing now, so basically I have this one case, and we'll take this in the. I'm going to again show you this memo and probably make your uh, uh, diagnosis or make your impression, and then we see the MR here. What did I do? So this is my mammogram, and so why I got this thing is because as we were discussing, Dr. Neeta, that like you now maybe getting to see less and less number of films and more number of links on your devices. Like everybody sends you those kind of.
Yeah. So I mean, it's often enough just a link in a that one is opening and sort of going through
Yeah.
that.
So these are the same kind of pictures or the same uh, this is the same link that whenever we give it to the patient, we give the same link. So this is how you will see the mammo. So this is the mammogram, extremely dense parenchyma, very difficult to kind of identify anything. There was a lesion, on the left side, and palpable concern was on the left side. And then we did for this, once the mammogram was done, we did an ultrasound and we found the lesion here. The lesion was seen in the upper inner quadrant. So again, now going back to one step behind when we are reporting, or it's probably my approach. I cannot kind of tell you like so. Before I open MR, like if I have a breast MR to be reported, I go back and see the ultrasound images, go back and see the MR, the mammography images, because I want to know what the question I need to answer when I'm looking at the MR. If whether it is a screening breast MR done for a BRCA patient or any high risk, is a indication is a high risk screen, or it's a diagnostic breast MR, because uh, sometimes we have kind of specifically asked because there was some clinical radiological discordance, or there were some additional lesions which were seen on ultrasound, but we were not able to kind of that looked like a disease extent, but we were not able to kind of characterize 100% on ultrasound the entire disease extent. So am I looking the MR for disease extent? Am I looking the MR for a screen? Is it a screening MR that I'm looking at, or it's something where there was a clinical radiological discordance and they were palpating something in some other quadrant, and we could not find that thing on mammogram and ultrasound. So before uh, even opening the scan, that's going through the mammo and ultrasound to find out why is the MR done is the most important question to be as a radiologist for me, which I want to answer when I'm reporting the MR. And this is what we tell it to all our students as well, to kind of first know why you've done the investigation and then kind of try to report it. So this was a lesion in upper inner quadrant, very extremely dense parenchyma, but we saw this lesion on ultrasound. And there were this additional lesions which was in the at kind of 9 o'clock position. Then there, okay, I think, and there was something on the at 9 o'clock again. The entire disease extent is from 9 to almost 11 o'clock position in the breast. There was some non-mass area in upper outer quadrant and axillary nodes which were suspicious nodes. So here basically I have done this MR for disease mapping. I want to exactly know from where to where the disease is going. So with this picture of mammogram and ultrasound, let's open the MR, how the MR is looking. So now I have MR. Okay. Yeah. So this is T2, T1, stir, and diffusion. Yeah. And I'm sorry, I have to rotate this because otherwise my right-left orientation just goes. So this rotation is not always necessary if your radiologist is always giving you in the upside down view and you're used to seeing the scan in upside down view. It's absolutely normal and okay to it's you can see however it is comfortable to you. So now, yeah. So again, this is like an if I go to see a fibroglandular parenchyma, extreme fibroglandular parenchyma, or very heterogeneous to extremely dense fibroglandular parenchyma. Now this is my T2 wetted images. I see this subtle area or the mass which is here. It's better seen if you kind of see the speculations are better seen on your this images, T1 weighted images. And as I was talking to you about the edema, you see there's a lot of edema here. It's kind of going behind the posteriorly. Whereas in this opposite breast, this is stir images. This opposite breast, what we are seeing is some cyst and multiple cysts that we are seeing. It's very heterogeneous again, parenchyma on some of these are cysts. Like as you see, these are hyper intense on stir and T2 weighted images. And at the same location, if you see on T1 weighted images, it shows signal drop. So this is cyst, a simple cyst within the breast parenchyma. And here that this edema, which is hyper on stir, hyper here on T2, you cannot differentiate. On T2, fluid and fat both are bright, whereas on T1, only fat is bright, fluid becomes dark. So here there is a shade of gray which is seen. So this is this edema which is behind this mass. Okay, so this much on on the non-contrast images. Again, one more thing is nipple. Like I am at the level of nipple and it is medial, so I'm at 9 o'clock position in the right breast. Okay, which was again the position on the ultrasound. So again, so if at times there are this clock position which changes between your MR report and ultrasound report, I believe you trust the ultrasound report because that's how you are going to operate in the operating table. The MR, as I said, it's the entire position. This is prone scan, and that is supine done ultrasound, which is more how you see in OT. So that correlates better with uh, what you will see or when you will palpate in the supine position. So that's now let's see the contrast scan. Okay, yeah. So I'm going to take this phases here. This is a routine dynamic phase. Takes a minute to kind of download these images. But in that much time, I'm going to rotate. So date. Oh, sorry. I hope you see this now better. So this is routine dynamic phase. And you see this enhancement, this enhancing lesion, which was at 9 o'clock position in the breast. There is a lot of enhancement in upper quadrant. The entire breast is showing like a significantly more enhancement. So this is a routine dynamic phase of the first phase of the conventional or a routine dynamic phase. Now, when I make a MIP images here, yeah. So here almost all the links do have these features, whatever I'm using right now to make it a MIP or change the window slightly. Maybe you just need to kind of try all these features and you'll be able to see the images better. So I'm taking this MIP images and I'm going to show you how it looks. Yeah, this is how it looks. So flip horizontal and flip vertical. So here there is significant background parenchymal enhancement, which is seen in the entire breast. There are multiple foci of enhancement. So suppose when I see a single such kind of focus of enhancement, I probably will go and do the relook ultrasound and try to kind of hunt for that focus of enhancement. But when I see like the entire breast, which is filled with lots of those foci of enhancement, I probably won't do anything. Now here again, now this is like your CC view of your um, uh, left breast, and you see that one lesion which is seen. And now there is a significant background parenchymal enhancement which is there in the rest of the breast parenchyma. So it goes like again the same question of what is the disease extent, or how do I know what till where you need to kind of scan, or how much you need to remove. I'll keep this image here, and now I'm going to show you some ultra-fast sequences and the difference with what we see on ultra-fast images. I'll take a fourth phase of ultra-fast because where I'm expecting maximum enhancement within the lesion. It takes like few seconds for it to make a MIP of that image. So many times it's not labeled as U ultra fast or routine dynamic. Is these numbers are mentioned, like it is from this sequence is subtracted and this image is created. So this is like, probably I should have taken the fifth phase. I want to change window here, but it's not changing. Mm. You see now the lesion? Sorry for this. Now this is again the MIP image of this fourth ultrafast phase. This was fourth, and this we have taken is a sixth ultrafast phase. You see the difference between the two. So this is what here, whatever we are seeing extra, that all extra enhancement is an enhancement of background parenchymal enhancement, which is kind of completely masked when we are doing the ultrafast sequences. Now, I will not, let's not see the ultrafast, and let's see now in this phase, like where only the lesion is enhancing. And let's try to find out if there is anything else which is showing enhancement. So I'm going to take it to the minimum thickness and I'm going to scroll the entire scan here from top to bottom. Let's me just make it little more brighter so that we can see, appreciate the lesion well. I hope it's not too dark. Yeah. So now I'm going to kind of go down. So I'm going from top. This is a focus of enhancement which kind of very distinct from rest of the enhancing foci. I will go and try to look for this focus of enhancement in the breast parenchyma. Now here I am, so I'm starting from top. I can see the arch of aorta. So this will be my 12 o'clock axis. From here it will start 1 o'clock and from here 11 to 11 to 10 o'clock. So I am seeing a focus of enhancement around 11 o'clock position here. Okay, my disease then there are these multiple foci of enhancement in the rest of the breast parenchyma. Then my disease is coming at the level of the nipple, so which will be around 9 o'clock. There is some additional focus of lesion, additional enhancing lesion, which is in the outer quadrant at 9 o'clock position. This also I would go and look on relook USG. And then this focus of enhancement, which is down. This will be, say, around 7 to 8 o'clock position. So on MR, for me, because this being a very early phase, 6th phase of ultrafast sequence, anything which is enhancing in so early which is kind of enhancing as intensely as the index mass. For me, these foci of enhancement, or these are suspicious foci, which is one is lower down at 7 o'clock, one is at 9 o'clock, and one is at 11 o'clock. I will go and do relook ultrasound and try to find these foci of enhancement, and probably kind of, if I can find it, and we discuss about this, like if the patient wants a conservation, maybe you want to do biopsy of these, we can decide the management later. The point that I want to tell you is sometimes some benign pathologies also can show so early enhancement. So which are those cases is one is lymph node, intramammary lymph nodes. Some papillomas show very early enhancement, like in 4th, 5th phase. So we do see these, kind of try to see these foci on your T1 and T2 weighted image. The lymph nodes have a very that reniform shape with the hilum. We are able to identify them on T1 and T2 weighted images. If we identify them on T1, T2 as a lymph node, then we don't chase them. But looking at this morphology, it doesn't look like a lymph node. So I will go and do a relook USG for this focus, this additional focus of enhancement, because here that linear enhancement is extending till the nipple. Here you won't be able to save the nipple in this case. And I will go and look at this focus of enhancement on my relook ultrasound. And then depending on whatever I find as a, this will be my disease extent when I'm telling you about the disease extent.
So
Yeah.
I'm going to ask Purvi here. So, there are going to be a lot of lesions that you just don't see on the second look ultrasound.
Yeah.
And you're seeing them only on the MR. Now, it's very difficult for us to plan surgery without now including these. And not everybody has access to MR guided biopsy.
So in those cases, the best thing is like we give you distance from like the upper margin of the index lesion, which is palpable. The superior most focus of enhancement is 2 centimeter or 2.5 centimeter from there. If we see some of these benign fibroadenomas, so we have marked that even before, like there is some fibroadenoma. Suppose if in this case, if I find at 12 o'clock and I see this focus of enhancement, which is medial, and I'm seeing that fibroadenoma on my relook USG, so I will rather mark you that fibroadenoma, okay, you kind of, if you go till that fibroadenoma, which is within 1 centimeter of this lesion, you will get this focus in your resection margin. But that comes as case to case basis, and what we are seeing on MR, what we are seeing on ultrasound, and how we correlate over there.
Fair enough. Okay.
Yeah.
I think it's already 8:40. Do we have any other questions from the group? Or we can see one more case then.
I kind of couldn't make a time.
So no worries. No worries. So then do we have any other questions from the group? So, basically, let me ask you this.
I
Purvi.
think there are a few questions which have not been answered. I think use of AI, MRI reporting,
So
concordance data.
I don't think that's going to be relevant because that's more for screening.
Yeah.
Will axillary metastatic lymph nodes also enhance early on an
Yes.
ultrafast MRI?
So all lymph nodes, axillary or intramammary lymph nodes, show early enhancement compared to normal parenchyma. The lymph nodes show diffusion restriction, also show diffusion restriction, but they have like to identify separately these lymph nodes from small fibroadenomas or this kind of satellite lesion. When we see a typical shape of the lymph node, only then we call them as a intramammary node.
Okay.
Unless we see that hilum and the periphery, this thing, if we don't see in any imaging, we don't call them as intramammary node or anything else. We will keep them as a focus of enhancement or enhancing focus if we don't find any correlate on ultrasound or T1 or T2 weighted images. Will ptosis affect the clock position? I think that is the same that we kind of discuss.
Right.
Yeah.
So basically, Purvi, let me ask you this, so if a patient doesn't come with a link and they come with films.
Yeah. So if you don't have a dynamic or your MIP images, I think then you ask them to get a CD.
Okay.
Because if you don't have
what films are we basically looking at to map disease for us?
Sorry, I missed it.
Which film should we sort of pick up to look at disease mapping?
So the contrast, the dynamic contrast, at least you need to have 3 to 4 phases to kind of see how the enhancement is going. And even if you have a single phase which is showing a proper enhancement, that is sufficient. But you need to have a subtracted dynamic phase for you and for us to see the images or map the disease. Without subtracted images, it is so there are so many lesions, as we were discussing, that there are so many lesions which are T1 hyperintense. This dynamic contrast images are T1 sequences. So if those lesions, like if I have a duct which is filled with a hemorrhagic fluid in its entire extent, I'm giving contrast, and now probably this duct is not enhancing, but if I don't, and I'm seeing only this images, I might consider that as a linear anemia and I will call it as a suspicious finding, whereas it was just a inspissated secretion within the duct, which is a totally benign finding.
Right.
So it will kind of subtract out in the subtracted sequence. If there was something hyperintense on your first phase, and it will subtract out from the second phase. So whatever we see is only enhancement. So many times that we have seen this, there is one very nice duct which is seen on T1 sequence. But when we see subtracted images, there is no enhancement. It is just a simple that inspissated secretion inside the duct, and for which we will do probably some surgery or microdocectomy or anything. So you need is subtracted images. In a one good phase of subtracted images is all that is sufficient if you're kind of mapping the disease, like you know, you want to kind of plan the surgery from where to where you want to go, one good subtracted image is good. But without subtracted, if there are no subtracted images, please kind of, you know, you ask them to get the subtracted images, because you will unnecessarily remove something which is not, which is probably benign, and you might kind of miss out on small those enemies, because those enemies you will not be able to see on non-subtracted images.
Fair enough. All right. I feel like I actually understood this, but Purvi, this is my problem. Every time you teach me MR, I learn that time and then I forget after 2 months. So I end up calling you for things again. So, maybe what we can do is, I think the next time we have some in-person meeting, we'll try and do some session, which is where we get multiple cases together and try and do something in person where, everyone can ask questions in terms of these are real. The best way to do this is get real world cases where we have struggled to map them and sort of plan them surgically.
Yes, that will be nice. And it will be, for me also, will be a nice experience. So we'll be happy to be there.
Perfect. Thank you so much, Purvi. Great having you. And thank you, everyone. We'll come back with another topic after about 3 months. Thanks.
Yes, thanks. Okay, bye-bye, Dr. Neeta. See you
Bye.
soon.
See you.